Hello everyone and welcome to the June issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. We continue our updated format, separating the cosmetic portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Rapid Pearls, will briefly cover the clinical application of the data from each article not covered in our Spotlight episode. Our goal with this format change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for June are Isabela Jones with Virginia Square Dermatology, who will be providing the article summaries, with George Hruza from Schweiger Dermatology Group offering expert commentary. We thank you for listening. We're hoping you're enjoying this new format, and as always, have a happy surgery day.
Welcome to the Rapid Summaries and Expert Pearls section of the DermSurgery Digest podcast. My name is Isabela Jones. I'm a dermatologist in Virginia. This month's featured expert is the esteemed Dr. George Hruza. Thank you for joining us today. This episode will feature quick article summaries and Dr. Hruza's rapid pearls from the articles published in the June 2026 issue of Dermatologic Surgery. Our first article is Assessment of Methods and Attributes Used to Characterize Skin Quality, a Systematic Literature Review by Shannon Humphrey and Sir Kurt Peterson. The authors aim to clarify the definition of skin quality, which is a term that is used by patients, physicians, and researchers. The authors conducted a systematic review of 903 studies on skin quality. 87% of studies used qualitative measures of skin, like hyperpigmentation, laxity, crepey skin, wrinkles, and dullness. 13% of observations included objective endpoints like size and frequency of pores and depth and width of wrinkles. Most of the objective measures have never been validated. The authors highlight the urgent need to standardize skin quality attributes and definitions in aesthetic medicine. They include a figure of their own proposed organization of skin quality attributes, dividing them into visual, mechanical, and textural domains.
Well, so I think that's great that they want to do it, because those are all good characteristics. My comment really is for the clinician. Those don't really make that much difference. And I'm going to quote Supreme Court Justice Stewart about pornography. I know it when I see it. And that's basically it. So when you see a patient, you're not going to try to analyze it in 4 different characteristics. You have seen thousands of patients, and you can pretty quickly kind of put it into, I like the Glogau scale, because that's a pretty straightforward, easy, and you can visually do it like 4 different levels. Really bad wrinkles, moderate wrinkles, mild wrinkles to no wrinkles. And then you can throw over on top of it the sun damage, because ultimately you're assessing actinic damage. So if you're going to have a Asian American who's 70 years old, their skin is probably going to look like a 30-year-old Caucasian who's been out in the sun. And so to me, it's really what we're really looking at is actinic damage mostly. And I think for clinicians, they're good at doing that, and everybody can have their own scale. For studies, it is important to have all those dimensions.
Thank you. Our second article is Mapping Filler Nodules, Ultrasound Characteristics and Clinical Patterns in Dermal Filler Complications by Chang and Liao. The authors aim to investigate the clinical features and ultrasound characteristics of dermal filler nodules. They enrolled 62 patients presenting with nodules between 2018 and 2024 in a medical center in Taiwan. In this population, over half of patients received hyaluronic acid fillers, and the rest had received other types of filler like polycraptolone and PMLA. 37% had received more than one type of filler. The median time from filler injection to nodule formation was 24 months. 82% of nodules occurred in the midface, and 5 patients had positive bacterial cultures. The authors describe the ultrasound properties of these filler nodules depending on the type of filler used. The authors believe ultrasound can be a useful tool in differentiating between infectious and non-infectious nodules helping determine the type of filler when unknown, excluding other granulomatous dermatoses, and identifying the size and location of the nodules.
Well, I thought the idea of ultrasound and what they found, that was, to me, that was fascinating. I thought of it like it's like we use a dermatoscope, which I'm still trying to figure out how to use well because it started after I was training. But to me, it's the same concept as just you go like into the skin. So I think the ultrasound part was really great. I was wondering why they didn't use hyaluronidase for those patients with the fillers, with the hyaluronic acid nodules. I mean, that's what I would certainly use to take care of the problem. And the 24-month delay was interesting because that's, the delayed reactions usually are just a month or two. So 24 months is surprising. And they had one patient that took 50 years to get the delayed reaction. So from silicone. So that was fascinating. I don't really see that the mixed fillers makes a difference. I don't think that they really showed that in the study. But the repeat treatment, I could see it leading to sensitivity. Like we have the issue with neuromodulators, we have the issue sometimes you get resistance. So fillers, you certainly could get more sensitivity and then get more the granulomatous nodules.
Thank you. Number 3, proof of concept, feasibility, and safety of local anticholinesterase treatment for neuromodulator-induced facial muscle paralysis by Steve Yellen and Mary Gardner. In this proof of concept, placebo-controlled, blinded, and randomized study, the authors conducted the first human trials on using anticholinesterase injected directly into muscles. The drug works by competitively inhibiting the body's own acetylcholinesterase in the synaptic cleft, leading to increased acetylcholine levels in the postsynaptic membrane. They had a complex study design, better demonstrated in their figures, but overall they had 12 patients undergo treatment with Botox to the glabella at doses of 20 and 10 units. These groups were then further broken down into individuals who were treated with the study drug versus saline at day 14, and they also kind of crossed them over. Their overall findings were that the group who received 10 units of Botox were more likely to respond to the study drug, as the response rates amongst the patients who had received 20 units of Botox were either none to minimal. Even for patients who did show a response, the results lasted 30 to 420 minutes, and 4 of the 11 subjects who received the study drug had non-severe and self-limiting side effects. The authors note that more studies are needed on reversal agents for botulinum toxin, and that perhaps a formulation of anticholinesterase with better duration of action and less solubility could perhaps be a promising drug.
So since both botulinum toxin binds irreversibly within probably an hour, maybe even less, and because it's an irreversible change, so the motor end plate is done, and you get a recovery because of a new motor end plates being generated. Suddenly, if you try to use it shortly after, the anticholinesterase treatment will have no effect. And then it showed that when the patient was getting very small doses of botulinum toxin, meant that they probably didn't have all the motor end plates gone, then you could have an effect. So down the road, it could probably be useful to get a faster recovery if you have a muscle that's paralyzed that you don't want. And that 11 days, maybe you can get there, probably couldn't because of the 20 units. So you probably have to wait 3 or 4 weeks. So there's not that much value there. If you do get a long-acting one, then at some point, probably halfway through, you could maybe get them a little bit faster to recovery. But I'm not sure that this is going to end up being something to actually be clinically useful.
Great, thank you. All right, moving on to the communications of the DermSurge journal. Autologous microfat and nanograft grafting combined with PRF in early treatment of atrophic facial scars by Akdogan and Kaliskan. The authors show a picture of a 15-day-old red and slightly depressed scar on the face of a 37-year-old woman. The authors treated the scar with subcision and fat transfer from abdominal fat. Microfat using a 1.2 millimeter filter was injected into the subdermis, and nanofat using a 600 micron filter was injected intradermally. The patient also underwent 3 separate injections of platelet-rich fibrin. In the 6-month follow-up picture, there is no visible depression present. The scar looks a lot better. Any pros from this article?
Well,
Mhm.
number one is, of course, since there's no comparison, 6-month scar is going to look a lot better than a 2-week scar. So it would have been good if they just did half the scar to see how it came out. But certainly doing fillers, whatever kind of fillers, may help. Whether the PRP added, whether the PRF added anything to it, we don't know. So clearly they did get somewhat of a nice result. We just need to see more patients to see which of the interventions had the impact. But certainly the filler, I think, is most likely what did most of the benefit.
Great. Next is sustained shift toward office-based care for dermatologic procedures, a cross-sectional analysis of Medicare data from 2014 to 2023. Using Medicare Part B data, the authors recorded the location of service for procedures like Mohs surgery, excisions, repairs, flaps and grafts, conducted by dermatologists, plastic surgeons, and otolaryngologists. In 2023, almost 96% of these procedures done by dermatologists were performed in offices, which was almost 30% higher than the levels in 2014. Plastic surgeons and ENTs utilize facilities or ambulatory surgery centers to a much greater degree. The authors comment that dermatologists deliver complex care with greater access and less cost by performing these procedures in the outpatient setting.
Well, to me that was a great article to say that dermatologist is where you should do most of these procedures. I mean, it's like it was, I think it was 23-to-1 ratio of dermatologists versus, office versus ASC. So clearly, office is the place where to go. The one other thing that was in the study that I noticed is that there's been quite a shift from excisions to doing more Mohs surgery. So that might undercut some of the cost savings, but if you look at recurrences and all that, maybe the difference isn't so great. But certainly Mohs, which is the most effective way to treat skin cancer, it seems to be used more often.
Great. Next article is Private Equity in Mohs Micrographic Surgery, Pearls and Pitfalls by Shane McTeague and David Harvey. The authors point to the growing presence of private equity-backed groups in healthcare, particularly Mohs surgery, and review the reasons why Mohs surgeons may want to get involved with PE groups. The authors list several items that should be carefully negotiated by surgeons looking to have a partnership with PE, including specific language to maintain surgeon autonomy over scheduling and practice flow, hiring and firing of personnel, taking time off for CME, and making sure surgeons have a voice against policies from non-physician executives. They also encourage having a clear compensation and bonus structure and a thought-out exit plan.
Well, the key reason for a Mohs surgeon to do this is to protect their referral base most often. Because if all these people come in and you're left holding the bag, you hold the referral base. So by joining group, you protect your referral base for the Mohs surgery. When you do this, you give up autonomy. No matter how well you write your contract, you'd give it up for the security of having patients, and you would have less regulatory burden. So that's the trade-off. I think it's good to do later in your career. Early on, I think doing your own practice is the way to go. You do want to negotiate everything carefully because they are very picky on that. You can't assume that anything that's not in there means it doesn't happen, just like you didn't write it in the chart. It didn't happen. Same thing with these companies. They are not your friend. They are your partners, but not your friend. And the other problem is once you sell, then the next turnaround, my mind is now on the second round, you have no control over where they sell, and then the contract, and you have very little leverage for your next contract. So you got to be aware of that too. Because my second sale, I've not been as happy as my first time it was sold.
Thank you. Next is state and federal malpractice litigation of medical liability claims involving Mohs surgery between 1988 and 2024 by Scott Stratman and Courtney Enslin. The authors found that between those years, the overall litigation involving Mohs surgery was low. Similar to older studies, they show that most legal claims relating to Mohs are against non-Mohs surgeons, and that delay of or failure in diagnosis is the most common reason for legal action. The top two reasons for litigation against Mohs surgeons were lack of informed consent and fraudulent billing, with the majority of lack of informed consent cases against fellowship-trained Mohs surgeons, whereas 100% of fraudulent billing cases were observed in non-fellowship-trained Mohs surgeons. The authors state that these findings underscore the importance of fellowship programs instructing trainees on the significance of proper informed consent and billing.
Well, it's a nice study to show that there's low rate of cases, but this is 17 cases over 38 years. And the vast majority, more than 95%, get settled out of court or dismissed. So I don't know if you can draw any conclusions because these are very unique ones, which are not what you see on the ground. So I'm not sure you can draw any specific conclusions. I think but clearly informed consent is important. The one that didn't show up, but I think sometimes happens, is wrong side surgery, because that makes it into that's kind of popular in the news, but where the orthopedic surgeon, cuts on the wrong leg or takes off the wrong leg and that kind of stuff. So even though in skin, it's not as big a deal, but still patients are sensitized to that and they can get very worked up.
Great, thank you. We have three more. So Article 8 is how we do it, optimal fixation technique for donor graft and suction blister epidermal grafting for vitiligo using one-sided adhesive dressing material by Alcatani and O. Suction blister epidermal grafting is a vitiligo treatment that involves the creation of subepidermal blisters by using low sustained suction pressure, then fixing the graft to the recipient area. The authors describe a technique of using a one-sided adhesive dressing material with a mesh-like structure to securely fix the donor graft to the area with vitiligo. The authors state this approach minimizes the risk of detachment or movement at the recipient site, ultimately increasing the success rate of grafting.
Well, I think this is a real nifty little trick, which you can also use in other settings, which many people don't do these vitiligo treatments, but you can use it if you have a thin split thickness skin graft, for example. You could put Tegaderm over it, and then you can do additional. You can even suture through that. But the idea is that it makes it doesn't tear as easily. The same, I use that sometimes when I have someone who's got very fragile skin, like on the arms, some older ladies with arms, they have the very thin skin, and you try to put sutures in and they keep cutting through. So you put the Tegaderm or some other dressing like that. And I think they use Mepitel, I think is the one they use here. And then you suture through the dressing, and that gives you extra support. So it's a clever little trick to use.
Thank you. All right, online article. A low-cost portable HEPA-based plume evacuation method for CO2 laser, radiofrequency, and electrocautery procedures by Kartikeya Agarwal and Saroj Agarwal. The authors state that some practice scenarios lack access to commercial smoke evacuators. Here they used a household vacuum cleaner equipped with a sealed HEPA filter during smoke-producing procedures. The authors know ease of use and a reduction in visible plume and in perceived odor. No concrete particle counts were measured, but they mentioned this is a possibility when there is no access to optimal smoke evacuators.
I think that's a great idea. This is clearly not done in the US because you're gonna have a patient there and you put you show that it says the household vacuum cleaner, the Dyson or something, and you're gonna have that attached. Patients would have a tough time with it. We used to have a Dremel tool that we used for our bone grinding, where you put the dental burr in there. Now I use a hand engine, so it's a little fancy. And some patients kind of thought it was pretty funny. So they said, "Oh, I have that at home." I said, "Yeah, you could probably do that on your own too." So I think it's great to have that if you don't have any option, but I probably would not be practical for a US-based practice.
Thank you. Okay, our last article is clarifying UV protection in automobiles when medical tint exemptions are unnecessary by Caitlin Curley and Aram Ilias. The authors summarize that most windows substantially block UVB transmittance, but vary in their degree of blocking UVA. In cars, the glass composition of front windshields blocks about 96% of UVA radiation. However, sidecar windows are made of tempered glass, and there is a significant variation with a range of 44 to 96% reduction in UVA. Therefore, the authors encourage discussing this exposure with patients with a history of skin cancer and extensive sun damage. They also clarify that to improve UVA protection, it is not necessary to use window tinting. There are modern, clear UV filtering films that can be applied without compromising visibility or violating state regulations. Window tinting reduces visible light in order to decrease heat and glare, but does not necessarily block UVA radiation as well.
Right, and we kind of knew that the darkening doesn't do anything for your UVA, which is what you're trying to avoid. It was interesting that the side windows is where it's a bigger issue, which I did not realize. So now you have a real good reason to say, well, so the windshield doesn't need it, and then you can be clear, which is helpful because the police don't like to have dark tinted stuff, even the sides, because then when they approach the vehicle, they can't see inside it. So that sets up a situation which already is tense, makes it more tense. So I think giving patients the option that they can get a clear film for their side windows and they don't actually need anything on their front window, I think that's great.
Excellent. Thank you so much for all your time, and thank you to our listeners for joining us.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.